it's my pleasure today to have a chance to have a conversation with Dr. Angelica Eddington. And she's going to be sharing some of her experiences and interest in the area of diabetes. But first, Dr. Eddington, if you would just kind of share us a little bit about your background and your training.
Wonderful, wonderful. Well, hello, everyone. Like Dr. Moen said, I'm Dr. Angelica Eddington. I'm a licensed pediatric psychologist. I'm also board certified in child and adolescent psychology. So a little bit of background about my training. I started my undergrad degree in actually an experimental psychology program, so it's quite different. So working in the rat lab and learning a lot about behavioral components for training animals. But then I got enrolled in the Ronald McNair Scholars Program. And so this is a program that's made intentionally for first generation doctoral students. And so in that program, I got assigned a mentor at the University of Texas at Arlington that was interested in pain rehabilitation. And so with that connection, I became interested in health psychology and applied to a graduate program at Oklahoma State University, working in the pediatric psychology lab underneath Dr. Larry Mullins, as you guys know already, in pediatric oncology. With that interest, I was in a grant where I worked with parents who had children newly diagnosed with cancer. So I got a lot of experience understanding family systems processes and also how a family copes with a child being diagnosed with a chronic medical condition. So I knew it was something that I wanted to do long term. So after that, it was just about finding my niche. So I matched for internship at St. Jude Children's Research Hospital. So for a year, I worked mainly in an oncology program. And then after that, I felt like I wanted to kind of spread from oncology to different areas of pediatric psychology. So I did a general fellowship in pediatric psychology at OU Health Sciences Center in Oklahoma City. Then I got exposed to all different types of chronic illnesses with children. So nephrology, working with the GI teams on inpatient units, whatever came in the hospital door, you name it, that was part of my fellowship program. After that fellowship program, my first faculty position was actually working in the nephrology department at OU Health Sciences Center. So in that department, one of the things that I was really happy about doing was integrating a baseline assessment for all of the kids that were diagnosed with end-stage kidney disease. So we developed a baseline and kind of followed the kids throughout that trajectory. And so that was something that I was very interested in, just creating integrated psychology care into medical care. I stayed in that position for about 3 years, and the chief of that department left and went to another university, another hospital. And so I thought it might be time to look for a different position also. And I found a position working in the pediatric diabetes clinic at the Barnard Children's Hospital in Memphis, Tennessee. Within that clinic, I kind of started the same protocol, having baseline assessments of kids newly diagnosed with diabetes and following them throughout their chronic illness regimen. With that being said, we noticed that there are a lot of psychosocial barriers that you can identify at the beginning of diagnosis and then help that child and that family just progress through their treatment. So currently, I still work in the pediatric diabetes clinic, and I've had the great opportunity to actually start a new position starting at Children's National Hospital in Washington, D.C., where I'll also be working with kids with diabetes and doing some of the same things, helping them cope through those psychosocial barriers at diagnosis and throughout the trajectory of their illness. So helping the kids cope, helping the parents cope, just general overall holistic care for having a medical condition.
Excellent, thanks. So when you go into the clinic and you begin to work with the families, what is it like when you first walk in? What strategies do you employ? What does that look like, especially with a child with newly diagnosed diabetes?
Most certainly. And so a lot of the times whenever I'm meeting with a family for the first time, there's a lot of shock. And so a lot of us that work with families that are newly diagnosed in any medical condition, there's that adjustment period. And so that adjustment period can look very, very different. Maybe you're learning terms that you've never heard for the first time. Maybe there's a lot of stress, a lot of anxiety. And so initially it's just to normalize the process of being in that adjustment period. And so you definitely want to go in, explain that psychology is just a part of the medical team. Our whole job is to help you and your family cope with what's going on right now. And so just normalizing the process of adjustment. That's definitely one of the first things I want to do, explaining that you have a medical home team. And so we're working together as an interdisciplinary team for you and your child. And then also making sure that we're doing some type of baseline assessment for mood and behavior so we can be the most helpful for the child. So for instance, if we have a child that's newly diagnosed that already has a history of behavioral problems, ADHD, how can we already implement behavioral plans so they are adherent to their medication? Or if we have a child that's already diagnosed with depression or anxiety, how can we make sure they have outpatient mental health services while they're going through this process? And so normalizing what's going on, and then also just assessing for any things that we can at the beginning to make sure that their trajectory goes as smoothly as possible.
So you really touched upon some of the special, unique challenges that some of these kids face, some of their families. Can you tell me a little bit more about what some of the barriers are to care, accessing care, the family?
Most certainly. So some of the biggest barriers can definitely be just health literacy at the beginning. So if you're working with a family who's never heard of diabetes before, or never heard of kidney disease before, just kind of giving that education. So reducing some of the uncertainty, ambiguous about what's going on. So what is this diagnosis? What do we need to know next? And so health literacy, making sure they understand what's going on. A lot of times it's actually getting, like you mentioned, access to care, actually getting to the appointment. I know one of the things that's going on right now with COVID-19 is this expansion of telehealth. And so one of the things that we realize is that for those families that may have transportation difficulties or maybe have other children and things of that nature, providing things that are virtual or electronic or telehealth can give them quicker access. Also, with that being said, we're also learning that everybody's access to Wi-Fi is different. So being able to assess what access to care looks like now. So is it physically being there? Is it virtually being there? That's definitely a barrier also. One of the third barriers that's really important is financial and insurance. And so for a lot of our families, even our families with private insurance, the cost of some of the medication, including insulin, can be high with private insurance or with Medicaid insurance. So making sure that we're problem solving how they can get their medication at newly diagnosis. And then on top of that, then it's also that parent involvement. With diabetes, there's a lot of health behaviors that you have to do throughout the day. And so that can involve checking your blood sugar 3 to 4 times a day, giving a long-acting insulin one time a day, but then giving a short-acting insulin every single time you eat your food. And so it's a huge lifestyle change. And so one of the biggest barriers also is helping the family adjust that this is going to be a lifestyle change. And so if you were the type of family that never had set meals, this may be more of a barrier for you than a family who was used to having set time meals. Or if you were a family where a child was that lock and key type of kid, so the kid who came in the house by themselves and kind of cared for themselves as the parent got off of work, that's also a big barrier that we work through. And so a lot of different barriers we try to assess at the beginning. It's actually recommended by the American Diabetes Association to assess these barriers at the beginning. But psychologists are so far in between in these clinics that those things don't always get assessed.
So those are some of the special barriers that you typically encounter in the clinic that you have to deal with. Okay. Mm-hmm. COVID has certainly thrown a curveball at us, and it has been one additional stressor for our families. Can you give me an example of how that's kind of played out in your clinic?
Most certainly. I think it's played out in different ways. So like I mentioned, the families that have access to Wi-Fi and maybe have other kids and maybe have other things going on, they do like the flexibility of telehealth or using things virtually. But maybe for the families that don't have the access to Wi-Fi or don't have stable internet connection, it can cause quite a barrier. And then also there's definitely a disparity in the people who are contracting COVID and definitely getting the vaccination and definitely getting ill. So it's definitely been quite a barrier. Also, when COVID-19, when the pandemic came out, one of the warning signs that they gave, the first diagnosis was diabetes. And so you're at higher risk if you do have diabetes. And so just particularly in our clinic, it did cause a lot of just initial stress and anxiety, just to even have the word diabetes listed by the CDC as one of the high risk factors. And so making sure that we're educating people about protecting themselves from COVID, and then making sure that they're still getting the treatment that they need. I will say that I think our clinic did a great job of making sure that we had all the social distancing protocols. And so we continue to provide treatment throughout COVID, even if that meant staggering out patients for education or staggering out patients for appointments too. So I think a lot of the same barriers that maybe other clinics, but for our clinic, I think with having that high risk population that was acknowledged by the CDC, it did cause a little bit more stress and anxiety.
I'm sure that it did. Well, this kind of leads into a discussion about this broader issue of health disparities that we see. You serve a
Mm-hmm.
high-risk population of kids. I'm just kind of curious as to your thoughts about how to deal with this ongoing challenge of health disparities in our country, and in particular with populations of kids with
Mm-hmm.
health conditions.
Most certainly. I think one of the things that definitely came out in the last year is I think the world understanding that maybe the way that we have been treating a lot of different disciplines, including medical care, is maybe not the best for the world that we live in right now. And so understanding that our world is diverse, our population is diverse, and that includes kids with chronic medical conditions. And so maybe the treatments, especially the psychosocial and behavioral treatments that we have been trained in to treat these kids, are outdated now. And so how can we make sure that we are modifying the way that we're delivering psychosocial care to our changing population? How can we make sure that all of the kids in the diabetes clinic, including our high-risk kids, including our kids that have transportation problems, are getting the same level of care? I think health disparities is something that's been going on for a while, but I think it's just more apparent. I think it's more of a buzzword now, which is completely fine if it's more of a buzzword now. That just means maybe we can draw more attention to how to implement things to decrease the health disparities. And so one of the things is just making sure that mental health and psychosocial care, that, if somebody gets a consult, if somebody has a correct insurance, or if somebody has the ability to come back for an appointment, they get mental health services, but it's actually embedded in the clinic. And so every single patient that comes in the clinic does get some type of assessment of your mood, behavior, your psychosocial stability. That's just one way. I mean, there's several different ways, but that's just one way to decrease health disparities. When you think about it, some of those mental health services that were being provided happen after the medical appointment. And so if it's happening after the medical appointment, you're already weaning out a set of kids to get that service. And that's one way that I think the health disparities, especially in the pediatric diabetes population, was just getting continued over time.
Right. I'm just kind of curious, do you have any other thoughts based on your experiences about other systemic things we can be doing to deal with issues of health disparity
Mm-hmm.
at the hospital level, at the insurance level? I'm just kind of curious if you could change anything, what would it be if you could wave that magic wand?
Yes, if I could wave the magic wand, we could help the insurance companies understand that everybody needs the same level of care. I think insurance definitely holds back a lot of services that we want to provide the kiddos. So for instance, there's a very specific example for kids with diabetes. In order to get what they call a continuous glucose monitor, you have to show that you've been checking your blood sugar 3 or 4 times a day with your meter and turn in those blood sugar logs to the clinic electronically. So if you think about all those steps that I just said, so making sure you're checking your blood sugar 3 or 4 times a day, making sure that you can turn in this blood sugar log electronically to the clinic, and then the insurance company will approve you for a continuous glucose monitor that you can stick on your skin, that makes checking your blood sugar a little bit easier. And so it definitely makes the quality of life with diabetes a lot better. But with all those barriers from the insurance company, you start creating a disparity between the population. And so for any of the families that have difficulty sending an electronic blood sugar log, they're not going to get that CGM. And so you're creating a barrier right there. And then also, so then you have the kids who have the CGM who are feeling a less better quality of life for diabetes, and then the kids who aren't feeling that quality of life for diabetes, and things just keep going. And so then for the kids who don't have that continuous glucose monitor, you start seeing the illness burden, or what we kind of call diabetes burden, diabetes distress. This kind of keeps going and keep going. And so then you're just increasing that disparity. And we all know as psychologists, the more that you have a lack of self-efficacy in yourself and your health behaviors, that just kind of keeps going and leads to medical non-adherence, and then leads to problems and long-term complications with diabetes. And then if we're being completely honest, unfortunately, early death and mortality rates for these kiddos. And so that's just one small example of insurance. But when you think about it long term, those are the things that are outcomes. And so how we can kind of help that is education is really important too. One of the things that I have found out is working with hospital officials and administrators is the lack of insight of what these things mean long term for the families. And so to help with that, as psychology, I think one of the questions was, what is the field of pediatric psychology in the future? I do think it's important for pediatric psychologists to advocate to be in administration, because we can speak to some of these health disparity trends. And we're definitely great researchers. We can kind of look at the research over time and help implement strategies to change those things. And so to reduce some of the systemic racism and bias that's in the hospital system, including more people who have like an open worldview, including more people who have been trained to be culturally humble. I don't even use the word culturally humble outside of psychology. I don't think other disciplines are even trained to even think that way. And so how can we do that? Just being more involved in administration, being more involved in leadership roles, and even kind of reminding myself of those things also.
That leads me to ask the question, if you were to kind of change the training of new young pediatric psychologists at the graduate level and during internship, how would you change their training to better address some of those issues?
I think definitely including a class on how to work in more administrative and leadership roles for the generalization of your services. And so it's great to be a great clinician. It's great to be a great researcher. But what does that mean in the real world, and kind of understanding the policies? I think as of recent, we have learned that psychology is significantly affected by policies. Our reimbursement rates, if we're not involved in these things, we're unaware. We're just unaware how our services are not being efficient. And so how can change that? Just adding classes like that. I wouldn't know the name of the classes, to be quite honest, but any classes on public policy and as it relates to psychology and mental health services. I think one of the things that I learned from yourself and Dr. Cheney, I didn't understand about insurance panels. I think you two were the only ones that mentioned that. And then the second time I heard it again, I think I was in fellowship. And so that was a gap in years that I didn't even understand how insurance can take a hold on how mental health services can be provided to individuals. And so adding more information about that, how you can get involved, how you can get involved on an administrative level in a hospital system. If you want to work in a hospital system, how you can get involved. If you want to kind of open up your own private practice, but what psychology means as in the world. So not just psychology in their own bubble, but how we are part of the team as in growth in any area, whether that's your pediatric psychology, counseling psychology, school psychology. You are not just a consultative service, you are a core service, and you need to be embedded in that core.
Absolutely, absolutely. So you have big plans for Children's National Medical Center, and you're looking forward to that new opportunity. Anything that you have up your sleeve that you want to see instituted when you go to the DC area and the clinics there?
A lot of different things. One of the things I definitely want to bring with me is starting that everyone gets some type of baseline assessment of like their psychosocial barriers at diagnosis, and hopefully longitudinally. That's something that I've done in each one of my positions, and I think it's really, really helpful for the families too. I've even had families say, I never even thought about asking that, or is that why such and such is happening that way? And so one of the things I hope that we can definitely implement is doing that. So integrating that in all the clinics. One of the things I mentioned, they're starting a pediatric type 2 diabetes clinic. And so a lot of times when you think about type 2 diabetes, you think about adults. And so I'm excited to kind of get that going. The research in pediatric type 2 diabetes is really rare because you don't see that much of that population. So that's the second thing. I've had the opportunity to be an AP, American Psychological Association fellow with LEAP. And so it stands for Leadership and Education and Advancement Plans. I think so it's for individuals that are looking to kind of transition from clinical work to a little bit of clinical research work. And so while I'm there, one of the goals is to submit a MPI project looking at motivational interviewing specifically in African-American children with diabetes. So working with some colleagues in Detroit at Wayne State University, still working with some colleagues in Memphis to try to get that intervention implemented into clinic electronically so it can reach a lot of different populations. So just expanding, continue what I'm doing, but expanding in a way so it can reach more populations.
Sounds outstanding. So, well, I want to wish you the very best of luck as you go on your next professional adventure. I want to thank you so much for sharing your insight into working with high-risk kids with diabetes. Thank you for giving us the time today for this interview.
You're welcome. Thank you so much.